Welcome to the Hematology-Oncology question bank on anal cancer. This presentation will cover key aspects of anal cancer from the question bank for board exams. Anal squamous cell cancers begin at the anal verge and include the perianal skin within a 5 cm radius from the squamous mucocutaneous junction. Tumors are classified based on size. You need to remember T1 and T2 size to be able to answer questions. T1 lesions are less than 2 cm and T2 lesions range from 2 to 5 cm. For patients with perianal cancer that is T1 well or moderately differentiated, or select T2 cases, N0, without anal sphincter involvement, local excision with clear margins is recommended. If margins are unclear after surgery, re-excision is preferred, but chemoradiation can be done as well. For poorly differentiated or more advanced cases without metastasis, chemoradiation with 5-FU and mitomycin is advised. For T1, N0 poorly differentiated, T2 T4, N0, or T1 T4, N+ cases, the preferred chemo regimen is 5-fluorouracil with mitomycin and radiation. Capecitabine can substitute 5-FU, and cisplatin can substitute mitomycin. The ACT-2 study showed that 29% of patients not in complete remission at 11 weeks after concurrent chemoradiation achieved complete remission at 26 weeks. Following patients up to 6 months or beyond after treatment may be optimal. According to NCCN guidelines, persistent disease should be evaluated initially at 4 weeks, then every 3 months for 2 evaluations, and if progression or persistence is observed, it needs to be treated. Surveillance for anal cancer includes endoscopy every 6 to 12 months for 3 years and CT scans of the chest, abdomen, and pelvis annually for 3 years. PET scans are not needed. For recurrent localized anal SCC, the NCCN recommends considering immunotherapy before proceeding to abdominoperineal resection, APR, if available at the institution where patient is being treated. APR is a very morbid procedure and is typically the next option for locally recurrent or persistent disease after chemoradiation. For metastatic anal SCC, the NCCN recommends first-line treatment with carboplatin and paclitaxel as the preferred regimen. Other options include 5-FU with cisplatin, FOLFIRINOX, FOLFOX, and modified DCF. For subsequent therapy in metastatic anal SCC, the preferred treatment options are nivolumab, pembrolizumab, and retifanlimab. Adenocarcinoma of the anal canal is the other type of anal cancer. This has a worse prognosis than squamous cell carcinoma. For T3 or any N+ cases, treatment involves neoadjuvant radiation and chemotherapy followed by surgery, known as total neoadjuvant treatment. Thank you for your attention. This concludes our presentation on anal cancer.